Hi everyone, I'm Stephanie. I'm the service lead for retinal screening at Counties Manukau. And you'll notice that today's talk has got a slightly different label. In your program it says ophthalmology. And diabetic eye disease actually sits mostly in community settings. And when we think about ophthalmology, we think about hospital-based services. Okay, so I'm going to talk to you about both of those today. Now, in everything in the eye department, we do in the dark, so don't go to sleep. Okay, so what are we talking about? We're talking about the eye, and thank you, Zarvin, for talking about pregnancy, because I'll go through that as well. Okay, so has everyone seen these photos before? Yeah? You awake? Yeah. Okay, so they don't project very well with our big light at the back, but this big white thing on the left-hand side, that's your optic disc. The optic disc is where the optic nerve joins the retina. It's an essential part of transmitting those neural signals from the retina back to the brain. What we're looking at mostly in our diabetic eye clinics are the blood vessels that sit on the retina. So those are those teeny tiny little vessels. Now these are micro vessels as opposed to macro. So whereabouts in the body do we also have micro vessels? What other part? Kidneys. I think you've been here before. Okay, so when we're screening, we're looking at those blood vessels. We want a good quality image. Occasionally, well, actually in counties it's not so occasionally, routinely we'll get images like this. Now this is an image of a patient who has lens opacities. Okay, so early cataracts, we can see our main structures, but we don't see the detail. So commonly these patients get sent for a second review, a clinical assessment. Sometimes it's in ophthalmology, sometimes it's in optometry based, depending where your service is located. Then we have these unfortunate cases. I hope you can all see the retinopathy there. Okay, so we've got the big hemorrhage there is a pre-retinal hemorrhage, or it's there because of the new vessels. So all of those teeny tiny vessels that you see are all new vessels. This patient was 34 when we took this image, and it was an opportunistic screening. She just happened to be in the practice when we happened to be there. And she had her 4 kids in tow, and we went, and the screener who took this photo, well, the first photo she took, she went, oh shit, because it was 5 o'clock on a Friday afternoon, and she didn't feel confident leaving this patient through the weekend. So she put the patient and her family in the car and drove them to the acute department at Green Lane. So the big thing here is that diabetic eye disease is the leading cause of blindness in our working population, okay? So it's not our old folk. In 2016, the ministry released another set of guidance documents for us. They were originally generated 2006, and in here it gives a framework for DHBs and how they deliver services. The most important thing in here is that the expectation is that services have a similar framework wherever you are in New Zealand. We grade the same, we recall our patients the same way. You can get a copy of this document, it's about 30 pages, by jumping onto the ministry website, just type in diabetic retinal screening. The scary part for funding and planning is that the ministry has stipulated that it would be ideal if all DHBs would screen 90% of their eligible diabetic population. So that is a massive ask, okay? Counties, we're seeing just under 60%. There is a Auckland Metro data project underway at the moment. It's got 2 phases. The first phase is to be able to quantify and describe the unmet population that are not screened. The second phase is to do an NHI level match and return that data to the PHOs to work with practices to ensure that patients who are not receiving screening are actually referred in for a service. So, we've touched on this already today. Type 2s, please refer at diagnosis or as soon as you can after. And please, please, please have a discussion with your patient about the fact that you're referring to the eye department or the eye service or retinal screening, whatever you call it in your area. Many patients will receive an invite. Because this is an asymptomatic disease, there's no pain, there's generally no change to the vision. I don't need that. What do I want this for? Okay, but if you guys have pre-warned them that this is part of their diabetes care and the expectation is that they need to attend, then we're more likely to get buy-in and get patients engaging. Type 1s, not as urgent for their referrals, 5 years after diagnosis or puberty, whichever comes first. Now, in counties, we're happy to accept referrals at diagnosis because that will give us a baseline for moving forward with that patient. And Zavin's already talked to you about pregnancy. So, what would your referral include? Really, this is the key. Duration is one of our biggest risks. We can't turn off duration, we can't control duration, but it's one of the biggest risks. The longer you have elevated blood glucose levels, the more at risk you're going to be, even if your control is good. HbA1c, any other complications or comorbidities. And really important, and this is where we lack information, is the bottom part. Please let us know if your patient has any of these conditions. And what that means is that when we receive your referral, we will triage that to the most appropriate clinic, okay? It's absolutely mortifying when a patient arrives at a community clinic in a wheelchair and there's no ramp. So, oops, didn't know you were in a wheelchair. Last month we had a patient arrive who was already blind, wasn't on the referral. So we invited him to a community screening. He got there, the screener was like, well, there's not a lot to be done. So just be really clear, and it helps us make good choices for the patient, gives them a good patient experience, because if they have a bad experience, what are they going to do? They're not going to come back and they're going to go and tell 10 friends who are going to tell 10 friends. And all of a sudden, that place has got a really bad reputation. Okay, so who remembers their eye anatomy? Nobody? That's pretty normal. Okay, so 2 structures we're going to have a look at today relating to diabetic eye disease. The first one is the lens, which is right up there at the top, and then the other one, which we've touched on already, is the retina. Okay, so the lens is at the front part of the eye, and it's what we use to control the focusing of the light that lands back at the retina. So, patients who report blurry vision, episodic, sometimes it's blurry, sometimes it's not, most likely to be a distortion of the lens related to fluctuating blood sugar levels. Okay, so if patients are reporting episodic blurry vision, see if there's a pattern. Is it after meals? Is there some rhythm? Did they forget to take their medicine? What's going on? And ask them if they've got a meter, if they could self-check their blood sugars at that time. Patients with diabetes develop cataracts earlier and they develop cataracts faster. And poorly controlled blood sugars lead to surgical complications once we do remove the cataracts. Now, one of the failings of public health services in cataract surgery is that once the surgery is complete, the patient is discharge back to primary care. We're trying to train our consultants that they need to think about diabetes and send those patients back to the screening service. Unfortunately, they're not perfect. So if you find a patient within your team that's been sent back to your care after cataract surgery, just let us know. Pop another referral and say, needs diabetic follow-up. Okay? Yep. No, so patients with diabetes have an override within the public service. So if consultants are unable to visualise the retina through standard practice of a slit lamp exam, then they will automatically get that second surgery, okay? Because it's more advantageous and cheaper for the government and for public service to actually take that cataract out than manage the manifestations behind that we can't see. Okay, so the retina. So long periods of hyperglycemia lead to changes in the blood vessels. We call it diabetic retinopathy. So what's actually happening? So there's two processes. One is where the blood sugar, as it's flowing through the vessels, damages the pericytes or kills them. So we get loss of those pericyte cells which form the structure of the vessel. So eventually over time they start to leak and bleed. The other process is around occlusion. So those blood vessels become blocked up, and from that blockage or the occlusion, past that we get hypoxic cells, okay? So those are the two things that are happening there. So our forefathers, when they were describing retinopathy, weren't particularly adventurous in how they described it. We have blot hemorrhages, we have dot hemorrhages, and we have flame-shaped hemorrhages, okay? So it's not very clever. So you can see in this image that the big blotty ones, we call them blots, and then there's the smaller ones, which are the dots, microaneurysms. But they basically tell us a bit of a story about what type of disease this person has. So when we're looking, people usually start to show up early retinopathy, just have the teeny tiny little dot hemorrhages. As the retinopathy advances, we get more of those. Then we start to see blots, and then we get some exudate, and then some other hypoxic signs start to show through. So the end stage is this beautiful picture, which is neovascularization or new vessels. So as a response to the hypoxic retina, which has been messaging the brain to say, hey brain, I need some food, can you send me something? The brain says, yep, I've got a solution for you. I'll build this network of new vessels to try and deliver that nutrients. The problem with these guys is that they are really, really delicate, and they break and they bleed. And then we have vitreous hemorrhages, which creates a sudden loss of vision. The white matter that you see in these images is actually fibrous tissue. So that's scar tissue. And what happens is if we get lots of the scar tissue in the retina starts to pull off the back of the eye and we get a retinal detachment. Okay, so it's a self-perpetuating process. We don't want to end up here. And unfortunately, in counties, we're seeing about 5 to 8 proliferative cases a month. Okay? A colleague who moved from Otago, when he first came up, he couldn't believe what he was seeing. He was like, oh, I have to get this. This is a great case. Oh, I have to get a copy of this. Because in Otago, they hadn't had one proliferative case in the 10 years that he was there. Okay, so unfortunately in counties we have some pretty sad stats. Normally in populations we have about 30% of the population have retinopathy and about 70% don't. In counties we have 66% have and the rest don't. So we are inverse to everywhere else, which if you're working in the clinics is great because you see fabulous pathology. If you're a patient, it's a bit rubbish, okay? So what are our risk factors? Duration is the biggest one, glycemic control. We have evidence, we have studies that show that a 1%, so that's in our olden language, so 6 millimoles or thereabouts, reduction in HbA1c will reduce the risk by up to 35%, okay? Hypertension is a big factor for progression, okay? Who's got a garden hose at home? Most of you? Who's ever had a hole in their garden hose? Yeah. So what happens to that garden hose if you just have the tap on a little bit? What sort of leak do you get? Just a puddle. What happens if you crank that garden hose, the tap up? What happens to that hole? Yeah, it's the same thing in the eyes, okay? We've got vessels that are a bit leaky. If we crank up that blood pressure, they just leak more. So when we're thinking about management, and I'm kind of getting myself a bit ahead here, think about bang for our buck. Blood pressure reduces retinopathy faster than our blood glucose. Our blood glucose is a long journey. It's months and years at a lower blood glucose than our blood pressure, okay? So when we're thinking about management, get that pressure controlled and work on the blood sugar as well. We've talked about pregnancy. In counties, we've started putting our eye services inside the pregnancy clinic and trying to capture those women. In the last 6 weeks, we've seen more patients in that clinic than we've seen in the last 9 months. Again, sad stories, proliferative and severe retinopathy cases. So some of those have been walked straight from the pregnancy clinic into ophthalmology and had laser. The other interesting one is a sudden improvement. So we all talk to our patients about controlling our sugars. The key for eyes is not to be Superman or Superwoman. We're not going from here to here in one single bound. Please, a nice, slow, steady decline in blood sugar, because a sudden drop will actually exacerbate retinopathy in the first instance. It may recover after that, but if a patient already has severe retinopathy, we exacerbate it to proliferative, there might be no coming back. So carefully does it, please. So I hear a lot that we talk in acronyms in ophthalmology. So this is the optic disc. The optic disc is a size. Every optic disc is different, and it is our measuring tool for the definitions of the eye. We call it a disc diameter. You will have all seen in your outcomes from screening or from ophthalmology that you have exudates within 1 dd or 2 dd, okay? The dd is your disc diameter. So the centre of the eye is the fovea. The macula is defined as an area which is 2 disc diameters from the centre of the fovea, and it's bounded by the inferior and superior arcades. So that is the blood vessels that go inferior and superiorly, all right? So when we're grading, we grade, each eye has 2 grades, a peripheral retina grade and a macular grade. Grading goes from 0 to 5, where 0 is nothing and 5 is end-stage vision loss. Okay, I would encourage you all to have a bold conversation whenever your patient goes from nothing to something. That's the first stage of end-stage retinopathy, end organ disease. Okay, a lot of times we see nothing happening until we get into the orange and red areas. Oh crikey, I've got to do something, what can I do? Too late, we're in vision preservation stage. Okay, so in those early yellow stages, good control, good management will send retinopathy back to a 0. Okay? All right, so digital surveillance or digital monitoring clinics are starting to pop up. This is an intermediary clinic between a photo clinic and a consultant clinic. In photo clinics, it's a two-dimensional image. We have no concept of depth, whether there's any swelling. We get a hint there might be something there, but we're not sure. So now that we've got technology, we can get patients into these technician or optometry or nurse-led clinics, and we can scan them and look at the depth of the retina. Is there any swelling? Okay, so the case on the left side, you'll see nice layers within that retina and a beautiful little dip in the middle. So that little dip is the fovea, it's the centre of our vision. That's where your fine detail is made, your colour vision, and it's the things that you're looking directly at. In the picture in the colour, you can see that that linear appearance has been lost, okay? And we've got a big black shadow. That's liquid that shouldn't be there, so that's edema, swelling. So this patient's lost vision. Okay, so I've talked about this a little bit and we've heard about it. So we're going to attempt to get an HbA1c of 55 or less. A big ask for some, but any reduction is a good reduction. Controlling of our hypertension, controlling of our other comorbidities, actively managing any foot ulcers, because there's a direct link to ongoing foot ulcers and the presence of retinopathy. We've all heard about it today. Actively encouraging that healthy lifestyle, looking at medications, how often are they missing it? Is blister packs an option? And of course, vessel health, we're looking at cessation of smoking. In the clinic, what do? We preserve sight as best we can when it's arrived. So this is an image of a patient who's had laser treatment. So laser treatment, you can see those little white spots, okay? We do laser treatment in the periphery, and that's called panretinal photocoagulation, or PRP, and in the macula we do it a bit more focal. We also have, so this laser is kind of an older technology, and now we're also using intravitreal injections, and it's really tricky to say to a patient, we're going to treat you by doing laser, or we're going to put a needle in your eye. For them running out of the clinic going, no, okay, we have to be really mindful about how we deliver those messages. This is a quick video on...
With laser surgery for PDR, the laser is applied to the peripheral retina, avoiding the central macula. This laser treatment, called PRP, or panretinal photocoagulation, and also known as scatter photocoagulation, causes the blood vessels to shrink and often prevents them from growing again in the future. It also decreases the chances of the blood vessels bleeding into the vitreous or causing a retinal detachment.
And this one, if you're a bit squeamish, sorry.
Okay, we put the lid speculum in, and I'll ask you to look up. Excellent, that just holds the eyelid open. I use a drop of providone iodine in the area of the injection. I like to mark the area where I'm going to place the injection. You might feel a little pressure as the injection goes in, but usually no pain. Withdraw the injection and use a cotton tip. Use a drop of antibiotic, and that's it.
Okay, so the health burden for those two procedures is significant. Laser is delivered every 6 to 8 weeks until the condition has settled. So that may be a number of years. The intravitreal injection is delivered in some cases monthly. So the burden on health systems with these interventions is significant. So, in summary, meaningful referrals, please. And if you're not sure, refer. And if you want to know a result, make friends with your local screening service or referrals coordinator. We are always happy to help. A big question there around if patients miss their appointments, you get a DNA advice, get them to pick up the phone and give us a call. It's easy to reinstate people. We'd much rather have that engagement than have people sitting out there going, oh, I missed my appointment, oh well, okay? Get that engagement. A call to action. If you have a patient who has greater than minimal, or the language that they use, minimal, doesn't sound that bad, okay? But they have some retinopathy. Or if they're changing grades, please have a discussion. And that link with your patients, checking with them, have they been? What happened? When do you have to go back? What did they say? Did you see the photo? Because most patients actually see their photos. And as healthcare teams, if you want examples, just let us know, because we're happy to give you photos that you can use as tools for education. What did they understand about their eyes? Is your patient management system updated with the recall date? Public service is not infallible. We maybe see patients every 2 to 3 years. Addresses change. We send out invitations, nothing happens. If you've got an active recall within your patient management system, are they due now? Have you heard from them? No, I haven't heard from them. Okay, give them a call. Okay? Enabling patients to take control of their health and their eyes. So, diabetic eye disease, treatable, avoidable, preventable. We don't have to have blindness because of it, but unfortunately, especially in counties, we have a lot of it. Thanks for listening.